Parkinson's physiotherapy. Physiotherapy may be required for the patient who is also receiving drug therapy or has undergone surgical intervention, or in fact, for the patient who is having no other forms of therapy. It is important to appreciate that the patient should be given help and advice by the physiotherapist as early as possible. Many patients are given diagnosis of Parkinsonism while in its very early stages and may be given no help at all because they are considered not bad enough to warrant drug therapy, physiotherapy, or surgery. This may be true of drug therapy and surgery, but it is not true of physiotherapy. The sooner the patient can be seen by the physiotherapist, the better, because it is easier to prevent loss of normal movement patterns than it is to regain them after they have apparently disappeared and abnormalities have become a habit. Less time is required for the initial treatments, and few more months or years or of relative independence may be gained by the patient. If the has had surgery or is receiving drug therapy, he may still benefit from the help of physiotherapist. By this time, he may well have had the disease for several years. The onset tends to be gradual, and the patient adapts to his symptoms so that the various movement problems become a habit to such an extent that he is unaware of the true degree of his abnormality. Drugs and surgery may dramatically change the situation and make more normal reactions fairly readily available. However, the patient may have forgotten the patterns and then will never realize his full potential without some help. It is important to appreciate that physiotherapy cannot bring about a reversal of the change which have occurred in the central nervous system as a result of the disease process. It is only possible to help the patient to minimize the effect of these changes by encouraging activities to remain as normal as possible. The patient's nervous system can only do its best in the circumstances, and the physiotherapist can only help it to exploit its full potential. Assessment. All patients should be assessed carefully. All patients should be assessed carefully since symptom will vary according to the stage of the disease and the effect of other therapy being used. Assessment procedures should follow the lines indicated, and a functional assessment for daily living activities should be preferably be conducted in patient's home surroundings. Treatment program. When the assessment has been carried out, an individual program appropriate to the patient's need can be planned with emphasis being placed on improving speed, mobility, and coordinated movement. As the patient will never recover from his illness, it is important that an initial intensive treatment program should be succeeded by reassessment and booster programs at intervals as necessity dictates. Rigidity and balance reactions. Treatment will almost certainly need to include activities to minimize rigidity and to improve the quality of balance reactions. The reader is referred to the chapter which emphasizes these activities. Application of ice packs prior to activity sometimes helps to promote relaxation of rigidity. The patterns used in proprioceptive neuromuscular facilitation techniques may be used to facilitate both limb and trunk activities. Isotonic techniques rather than static posturing and stabilization should be used, as these patients tend to be static anyway as a result of the disease process, one of the greatest difficulties being to initiate movement. Therefore, a rhythmical technique is used to reinforce initiation of movement. The physiotherapist moves the part to be exercised passively through a small range of pattern several times, thereby setting up a pace or rhythm for the patient to follow. After several passive movements, the patient is asked to assist the physiotherapist in the same pattern, still utilizing the rhythm set up with the passive movement. These small range reversals can gradually be increased in range and speed. This pumping up into an activity can be used as a preparation for all activities, and the patient may ultimately learn to prepare himself for movement by carrying out repeated simple swaying movements until he is sufficiently loosened to be functioning effectively. The patient needs practice in carrying out movement rapidly and smoothly. Patients who have difficulty in initiating walking may be helped by marking time on the spot first, and once the smooth rhythm is established, can then proceed forward. It is sometimes useful to include rhythmical activities to music to assist gait. Arm swinging needs to be encouraged, a lengthening of the stride, and also practice in stopping as well as starting, walking backwards, sideways, and turning without overbalancing. Control of head and neck activities. In the Parkinsonian patient, there is a tendency for the head to drop forwards for the thoracic spine to show an exaggerated primary curve of flexion. This is not good for the respiratory movements, makes equilibrium reactions even slower, and inhibits speech, mastication, and deglutition. Such patients may also complain of pain and discomfort in the neck and shoulder regions, which is due to irritation of the cervical nerve roots. Conservative physiotherapy may help to relieve this pain, and general activities already mentioned may well have the effect of automatically improving the functional posturing of the head and thorax. Far reaching effects are often achieved by using trunk and balance activities without the need for specific head and neck activities. However, if automatic improvement of the head and neck posturing does not occur, some emphasis may be put on the cervical spine by giving assisted active head movements suitably coordinated with the movements of the whole body as a whole. The patient should be encouraged to lead the upper trunk by using head and neck movements, and if upper limb reversals are used, the patient should follow his hands with head and eye movements. Specific proprioceptive neuromuscular facilitation techniques may be used for the redevelopment of head and neck patterns, and the methods used are similar to those advocated for the limbs. Guided reversals through increasing ranges should be encouraged and stabilizations avoided. In addition, respiratory exercises should be encouraged so that the danger of chest complication is minimized. Many people advocate the use of cervical collars for advanced cases, and they may indeed be necessary if there is a danger of peripheral nerve root compressions or cord damage. However, collars will inhibit movement and should only be used if absolutely necessary. Problems of mastication, deglutition, and speech. These are present in many patients demonstrating Parkinsonism and are particularly obvious in the most severely affected patients and those who have difficulty in controlling the position of the head. Inactivity of the facial muscles and in particular of buccinator allows food and saliva to escape from the mouth and collect in the area between the cheeks and the teeth. This results eventually in distressing and unsightly dribbling at mealtime and even at other times during the day. The patient becomes very embarrassed by this and feels socially unacceptable, which in fact he is, particularly to the people who do not fully understand his condition. The tongue and supra and infrahyoid muscles will also present problems, and difficulty with deglutition will be experienced. Speech is affected by the inactivity of all the muscles and also by difficulty in vocalization due to respiratory impairment. Stimulation of the tongue, facial muscles, and hyoid muscles may be brought about by icing inside the mouth, the surface of the tongue, face, and anterior aspect of the neck. Light stimulating massage may help to activate the facial muscles, while respiratory exercise and chest percussion may help vocalization. Great attention must be paid to head posture since deglutition and tongue movements can be severely impaired if the neck is in a non-functional position. For this reason, it is important to see that the patient with poor head control is upright and well supported at meal times, with the head and neck in a good position for performing the functional movements associated with eating. Icing the tongue, cheeks, face, and neck prior to attempting to eat may help the patient to cope with the problem and make mealtimes more enjoyable. Inexperienced nurses and relatives often need help on these matters if undue distress to the patient is to be avoided. Advice and assistance for the patient at home. Relatives and patients should understand that prolonged periods of inactivity are detrimental to the patient. There are many ways in which help can be given. One of the worst times for the patient is on waking in the morning, because he has probably retained one sleeping posture all night and become genuinely stiff and immobile by the morning. If the problem is severe, the relative may be required to loosen the patient passively by helping him to rotate his trunk. The less severe patient can help himself by turning over a few times before trying to get out of bed and by sitting on the edge of the bed. Clothing can be made easy to fasten and of material which are not too resistant to stretch. Clothes can be placed on both sides of the patient so that he has to turn and therefore rotate his trunk to pick up each article. The patient can learn to help to loosen himself by swaying his body weight in different directions before he stands up and attempts to walk. Any job he does about the house should be as active as possible, and sedentary work should not be carried out over long periods. Such patients are often unable to detect fatigue in themselves, and while encouraging movement, it is important to avoid overdoing any one activity. Frequent changes of activity are helpful. A few weeks of intensive physiotherapy and advice to both the patient and those with whom he lives will help him to realize his full potential. Therefore, the management should be restricted to checkups and occasional booster periods of treatment. It is useful to visit the patient occasionally at home to see him in his own surrounding, and relatives will, in this way, be kept fully in the picture regarding his capabilities. Occupational therapists and physiotherapists need to collaborate closely, since many patients can retain their functional independence with the help of some simple gadgets and instructions from the occupational therapist. The help of the social worker may be needed in certain circumstances, and the local authority can be approached if alterations to the home are required.